Nice to be back. And we're going to do a lot today. And basically, we're starting with just a 15-minute science piece. And then from there, we're going to move into our major presentation for you. So I'm just going to give you a little slice of breathing science. And I just want to sort of back up here for a minute on the subject of breathing science. When we talk about breathing science, we're really talking about two different fields. One is physiology, looking at the physiology of breathing and respiration. And the other one is behavioral science. It's really psychology and physiology. And so we're going to be doing a lot of applied behavioral science in the last half of what we do this morning. That is, we're going to do a demonstration as to how we do our work. But I just want to mention a few things before we get started. One, we will have some instruments set up out here. What we're doing today is science, technology, and psychology, if you will. We're doing all of those things. But we're going to, in the afternoon or throughout the day, today and part of Saturday and probably part of Sunday, we'll have 3 instruments set up out there where you can have your breathing essentially looked at from the perspective of respiration by working with Sandra, or over here with Lisa Kusch, or Wolf Fellner over here, who I'm going to briefly introduce. Lisa did her master's degree in breathing science with us quite a number of years ago and is now on our faculty. And she's very involved in everything that we're doing. And if you are Canadian, be sure to, establish a connection with her. And then Wolf is from Austria, who came all the way here for the meeting. He was in Venezuela, and he flew all the way back from, his wife was from Venezuela, and he flew all the way from Venezuela to Austria, stayed there 4 hours, and then flew here. And so Wolf has his professional diploma with us. He's an economist. He's a very accomplished economist who got really interested in breathing science. We've been very connected since then, and he's very involved in everything we're doing in our school. He's also on the faculty of the school. He's very involved in the technology, as is Lisa, and so on. In fact, both of them played a big role in testing out our new instrumentation we've now had for 23 years, but this is brand new. Some very cutting-edge technology. It's taken us 4 years to develop. Anyway, they're very, very involved, and they're also very, very close friends of mine. So you should know that, both of them. And so they'll be out here with Sandra, who is, if I didn't say, my life partner. She's not just my partner in doing our professional work and developing what we've developed, but we've been together now 22 years, which I don't think I mentioned that. So in any event, I'm going to start with a little piece of physiology that I think every person who's doing breathing work in their professions should know. It's about respiration. It's about breathing and respiration, okay? And this is really fundamental. And I'm going to talk about what is optimal respiration, okay? Breathing is, one thing to understand is breathing and respiration are not the same thing. And so what you think is good from a breathing perspective may not be good from a respiratory perspective. They're very different things. And in many languages, they're not. Like in Spanish, respirar is to breathe. But there's no separate word. It's not like breathing and respiration like we have in English. And that's fortunate for us who speak English, because these are two different things. If you have one word for it, it's hard to talk about them as being different things. And breathing is something that we'll get into. It's a behavior, and that's a very important thing to understand, that it's a behavior. Whereas physiology, what we're going to be talking about now is a lot of it is reflexive. And this is a very important thing for you to know. It's August 18th right there, and I'm just going to flip ahead to that slide here and just start off with this. This is an equation. that everybody who does breathing work should know. Okay, and it's very simple. It's very well established. It's in every pulmonary physiology textbook. It's in every acid-base textbook in the world. Every physiologist knows this equation. Anyone who does acid-base work knows this equation. It's just fundamental, and it's simple. It's a little more complex if you really get into it, but it boils down to this, and that is pH. Everybody knows what pH is. The pH of the extracellular fluids of your body, which includes blood plasma, which is really important, and the cerebral spinal fluid, and the lymph fluid, and all the fluid that surrounds all of the cells in the body called interstitial fluid. All of those fluids obviously have a pH, and that pH is regulated by two things. And this bracket here means concentration. The concentration of bicarbonates, an electrolyte, concentration of bicarbonates, say we'll talk about blood plasma, okay, divided by the concentration of carbon dioxide that's in your blood, in the plasma, gives you your pH. It's that simple. And the kidneys control this, the bicarbonate concentration. And it's a very slow process. The kidneys, when they come into play, it's not something that happens right away. It takes a period. It can take days for it to do its job. And it's controlled by the bicarbonates. And the kidney actually makes new bicarbonates, and it takes old ones that have been filtered out of the blood and restores them to the blood. So the kidney regulates this. The CO2 concentration in the blood is regulated by breathing. Okay? And so if you change the CO2 concentration in the blood, you immediately change the pH. So, and how is that regulated, this CO2 level in the blood? It's all about how much carbon dioxide you keep in your lungs, specifically the alveoli of the lungs, where the gas exchange is. You have to keep a certain concentration of carbon dioxide in those alveoli at all times. And whatever the concentration is in those alveoli, as the blood comes through from the heart into the lungs and into the capillary network, the pulmonary capillary network, the blood gives off carbon dioxide, okay? And it'll give off the amount, it'll give off enough so that the CO2 concentration in the blood is equivalent to the CO2 concentration in your alveoli. So when the blood leaves the lungs, it leaves with a concentration that is almost exactly the same as the concentration in your alveoli. So you have to keep the right amount of CO2 at all times in the alveoli so that the blood leaves with the right concentration. So this is the CO2 level in the plasma. This is the concentration. And what that is depends, again, on how much CO2 you've maintained in your alveoli. So if you change the way you're breathing, you change the pH. So if you get in there and take a larger breath, you start to ventilate this off. You lower the amount that's in the alveoli. The CO2 concentration will go down with a larger breath. As you take a number of large breaths, if you try it sometime, I get dizzy, and maybe 2 large breaths, I start feeling dizzy. Okay? And the reason that's true is because this CO2 level is dropping and the pH goes up. This becomes a smaller number. This stays constant. And if you divide this by a smaller number, the pH will be higher. It's mathematics. So as you get involved in your own breathing and change it, you're changing pH.
And when we talk about breathing as behavior, it gets very interesting and exciting, like yesterday during one of the events where we were toning and using vowel sounds. When you're coordinating speech and breath, that's one way of getting involved in breathing behavior. And of course, with different languages, depending on the melodiousness of the language or the sharpness of the language, when we call it aborting breaths or cutting off airflow in order to make sounds, or pre-verbal sounds, or moving the air rapidly or slowly, singing where you have to project your sound if you don't have a microphone, the way you're moving that airflow, the volume of air, it can all impact what Peter's talking about, the pH. And you may actually notice different changes in your consciousness or your muscles, or depending on if you have a pre-existing condition or a propensity for certain concerns, then those concerns might emerge in those moments. And you might even think back in your mind, well, I wonder if the way I'm breathing in this moment is affecting my pH.
So what happens is you suffer from what's called respiratory alkalosis, is what it is. The pH goes too high. And I'll mention some of the things that happen as a result of that in just a second. But the point here is that acid-base balance is equal to bicarbonates divided by breathing behavior. So when you take an action, that's a behavior. Any physiological change in my world is behavior. So when you change your breathing, you're changing your behavior, and when you do that, then the acid-base balance is changed. And that's why when you look at the statistics I mentioned yesterday of 60% of the ambulance runs in the major cities in the United States are a result of acute symptoms brought on by disturbing this equation.
And behavior becomes interesting as well, because there's our personality, the way our personality may behave, and then there's our body and our cells, the way they behave and what they learn to do. We often talk about blood sugar changes as being learned. People who talk often about, oh, I need to eat something because I'm starting to get a headache, or I'm starting to feel like my body is telling me it needs something. And that's learning. It's the cells learning. We teach our bodies how to behave, basically, in addition to the way we breathe.
Anyway, here you have what we call learned overbreathing behavior, and it's called overbreathing because basically you're ventilating off too much carbon dioxide. And you get into trouble, as you'll see. So as the CO2 level drops, the pH level goes up, and you end up with a deficit of carbon dioxide, and that's called too little, capnia, which is CO2. And this is what we call behavioral hypocapnia because people learn to do this. We all have breathing habits, which is what we're going to be looking at later. When we do a demonstration, I'm going to be talking all about breathing habits. And so people when they have a habit that leads to a deficiency of CO2 in this subsequent rise in pH, we call it behavioral hypocapnia. Everybody knows what hypocapnia is in physiology. There isn't anybody who doesn't know what that is. You would learn that in Physiology 101. And that equation is that you just saw is fundamental. It's no theory. It's been around forever. That's what's used in surgery. When they monitor CO2 during surgery to keep it just right. Because if it's not right, your patient is in bad trouble. So capnometers are used to measure the CO2 concentration in your blood by virtue of measuring the CO2 concentration in your lungs, because they're almost perfectly related to each other. So they use capnometers in critical care, in medicine everywhere. Every ambulance has one. They're everywhere because it's just fundamental physiology that's so critical to being able to be healthy and to be able to perform, and so you're looking at it all the time in medicine in critical situations.
So today, with the instrument that we brought, you'll be able to see it's measuring in millimeters of mercury, but it's a match to the pH. So it's the same type of technology used in critical care.
See, here's what happens to the brain, for example. This is a slide of a scan done at Yale University School of Medicine. And this person was what we call moderately overventilating. Someone who, like I was speaking with a woman yesterday, I can't see her here, she was talking about how often she doesn't know what to do in a situation other than to take control of her breathing. You know, that's a way that she feels in control. So a lot of people take control of the breathing and make themselves feel better, okay? And this is a psychological thing. You know, I need control, I take over my breathing, and as a result, you mess up that equation, and this can happen in no time flat. This is showing you oxygen content in the brain. And these yellow and red is the highest concentration, dark blue is the lowest level concentration of oxygen. And you can see that when the person breathed moderately over-breathing, nothing serious, this person lost almost 40% of the oxygen in their brain because of the reduction of blood flow in the brain. And that doesn't count the fact that hemoglobin itself, as I was mentioning yesterday, is less friendly. So it doesn't want to give up its oxygen as easily. So there's less oxygen and it's less accessible at the same time. And so this has a dramatic effect on people. And the psychology of it is extremely important because if you suddenly get dizzy and disoriented, some people, when they feel that, see, this is a breathing problem, they feel the disorientation, and here's what happens. Oh my God, I can't believe it, I'm losing control again. I'm losing control. What's happening to me? The next person goes like this. Hey, this is really great. I really love this. This is really something. Boy, this kind of breathing, I think I'll practice doing this. Because this isn't a physiological thing. This is your learned response. This is your learned response to the symptom. And we're going to be looking at a lot of that when we do a demonstration. We're going to be looking at learned responses to symptoms. And it's not just the symptoms, it's if the way you're breathing, your experience of your breathing, like you feel yourself breathing fast or slow. Some people, when they find themselves breathing slow, panic because they feel like they're suffocating, they're not getting enough air, and they reach for more air. And they keep reaching for more air because the breathing was too slow. They're sure they're not getting enough air. It makes them really anxious to breathe slow. Unlike what maybe you thought, that it's fast breathing that produces anxiety. Slow breathing relaxes people. No. Some people relax when they breathe slow. Other people relax when they breathe fast.
And then
it's a learned response to the experience of a particular kind of breathing that we attend to in our work. And if someone is breathing fast and it produces anxiety, what do? We don't teach them to breathe slow. You know what we teach them? To breathe fast without being anxious.
Right. Peter's also talking about these are some of the initial behaviors that we're looking for, but then there are so many layers, right? What Peter's describing about somebody feeling anxious and taking control, and then the response to that can reinforce the interest to continue to do that very behavior, which then actually may become, we talk about conditioned responses, where you now go to that automatically and maybe unconsciously, where it's no longer something you're doing intentionally. And then how you do that is, are you taking a lot of air, a little air, breathing more fast, breathing deep, using accessory muscles? Are those accessory muscles bringing on muscle tension? But that's the price you pay to feel euphoric. There's just so many nuances. It gets very rich and in-depth.
Well, you can think you're doing great things by, for example, having people take deeper breaths to relax. But that doesn't change the fact that you've disrupted the equation. Mm-hmm. It doesn't change the fact that you have compromised respiration. It's just that the person's response to that experience may be one that's positive, and that may be the reason they continue to do it. Here's an example. Someone is suffering with trauma. They have really difficult memories, really hard for them, post-traumatic stress syndrome, or maybe PSD from some kind of abuse as a child, or whatever it is. What will happen is if they overventilate a lot, most of these people end up learning to overventilate. And what is it, and why? When you look at it, what it does is it allows them to control their memories. So what they do is they escape a memory. They get away from a memory. They feel safe when they overbreathe. They feel better. They dissociate. They disconnect. They go into a different state. They no longer access that memory that's ever present. So they go there to be safe. They don't realize that they've learned this. They feel good when they're there. They pay the tremendous price of compromising respiration, as you'll see here. But nevertheless, this is a psychological thing, something that they learn to do. Now, other people, maybe like, say, holotropic breathing, or people overventilate to, trigger memories and all this kind of stuff. It's the opposite. Just goes to show you how psychological it is that one person, they do it to avoid memories, and in the other case, they get memories. In one case, they're doing it so they go back to a difficult time and try to work it through. Maybe this, when you think of holotropic breathing. But lots and lots of real human beings out there are doing exactly that to accomplish the opposite, to escape themselves, to disconnect from themselves. So to understand breathing, you have to look at the psychology of it. You can't just say mouth breathing is bad and fast breathing is this or that, or this kind of mechanics is good and that kind of mechanics is bad. To really understand why someone's breathing the way they are, you need to understand, talk to the person, find out what's going on, which is what we're going to do, where they then self-discover why they're breathing the way they are, how it's affecting them, and how they can make a change. So here are some of the effects of hypocapnia or overbreathing. Underbreathing, as I mentioned yesterday, is very uncommon. People don't generally ever underbreathe unless they're not exhaling. Some people will not exhale, and as a result, like I was just talking to a gentleman here earlier, who we might have come up for a demonstration, where I had the impression, based on the discussion I had with him, because he can't get his breath, that he's not exhaling. So if you don't exhale, you only exhale partially, then when you go to reach for a big breath, what are you going to find? You're going to feel like you can't get a breath because you haven't exhaled completely. So then you get into a vicious circle, and you're constantly trying to get a breath because you're not exhaling completely. You get air hunger, and when you have air hunger, then you try to breathe more and you end up overbreathing.
And that's oftentimes because the culture tells us to take a breath, right? We need more air. Take a bigger breath, take another breath. And then the person may be taking more and more until now they're not even allowing the exhale to be complete enough. They're just trying to reach for more air. And that becomes it's such a profound realization to have that. If that's something you've noticed, you've experienced, well, maybe I don't need to take this huge breath. Maybe if I allow this exhale, I'm going to allow my chemistry to operate and take care of me and support me in the way I need. I don't have to take control. My body is my friend, it's my partner, and I can partner with my chemistry. So it becomes really important to understand the chemical part of the behavior.
So we're going to get more into this, but right now we just want to get past this piece of the physiology that's involved in it. Because what normally controls the breathing are reflexes in the brainstem. And those reflexes are sensitive to the following things. There is input from the arterial system in your body about the CO2 concentration in the blood. And there's input about the oxygen concentration in your blood and the arterial system, like in the aorta. And there are also receptor sites that measure the pH of the plasma of the blood. So these are 3 kinds of receptor sites that are specialized. And that information goes to the brainstem. Then in addition, there are receptor sites actually in the brainstem that are exposed to cerebral spinal fluid. And there are these receptor sites that look at the CO2 concentration in the cerebral spinal fluid, at the CO2 concentration, and the pH of the cerebral spinal fluid. Those factors is what governs breathing from moment to moment. Like I hear a lot of times people will say, well, mouth breathing causes people to overbreathe. This has nothing to do with, whether you're breathing through the mouth or through the nose or whether you're in the diaphragm or the chest or whatever. These things are not the relevant considerations. It's all chemistry. It's chemistry that regulates it, that I just mentioned to you. And it does it very often to a great degree through the use of the diaphragm and the external intercostal muscles, so that when you go to the chest and you reduce the involvement of the diaphragm, you can get into trouble. That's why one of the reasons why chest breathing is an issue. It's because you can take control away from these reflexes. The idea is to allow these reflexes to operate. Now, here's some of the things that happen. And then we'll cut off this little introduction, one little piece of physiology. I think it's so important for you to know. Look at all of these changes that occur, and the physiology of it is very well known. In our course, for example, we have like a 6-day course, in this kind of thing in our various programs where we teach all this, because there's real physiology directly behind all of this. And you can look at it. Look at the first one. You can get nausea in a minute. You can get vomiting easily with hypocapnia. You can get cramping in the gut, bloatedness. All of those things, the chemistry and the physiology behind it is well known. So you look at pregnancy, for example. Hypocapnia can contribute significantly to nausea and can bring on the nausea, as almost all pregnant women are hypocapnic. And you're going to get symptoms from that. And it could be any of these symptoms that you're going to blame on pregnancy or on hormones or something without understanding the psychology of what's going on. When you have pressure on the diaphragm, you're trying to breathe and you have this child developing, you pressure on the diaphragm, that can bring on air hunger, so you try to reach for air. But in medicine, it's explained as being a result of hormones, and therefore, in essence, you can't do anything about it because that's part of being pregnant. Fact of the matter is, you can teach women to keep their CO2 levels normal, which Lisa can attest to over there because that's one of her specialties. You want to say anything about that, Lisa? About pregnancy and symptoms and hypocapnia? In your experience?
Just a second.
I think that it's a perfect example when you're looking for the behavioral connection of something that we have as a culture propagated as normal or typical, and that we just have to learn to live with something when we're pregnant, when actually we've disrupted the chemistry of our body, but then we've told ourselves the story that it'll be over soon, and we perpetuate it. And it also links into postpartum depression, which is another conversation.
So you see, these are very significant. I can example of people vomiting who think it's because of the drug they're taking, some kind of they're taking drug for pain management, for example, and they're vomiting and they blame it on the drug. I know this physical therapist who then works with people who are nauseous and they're vomiting when they have pain, only to show them how breathing is mediating that physiology directly. I mean, really incredible stuff. Autonomic. You look at fatigue and headache. Well, headache comes on with what? Lowering blood sugar in the brain. When you overventilate, what do? You reduce blood flow up to 50%. Some people say 60%, some of the literature. And then you get a headache. In a minute or 2 minutes, you're in a serious headache. You're suffering with hypoglycemia in the brain. And then what are you going to do? You blame the headache on something else because you don't know where it's coming from. Oh, it must be stress.
But
And then everybody believes that it's the stress rather than your learned response, your learned breathing response to the stress.
Exactly. Picking up on where we were touching on yesterday with the myths and beliefs, when the nausea may come on, or this is going to be over soon, like Lisa was mentioning with a pregnancy, the belief again that I need to get more air, reinforcing even maybe more nausea, and or more fatigue, like Peter's talking about with the autonomic stress. So how we understand and what we think about breathing and the behaviors we choose to engage can reduce or increase certain symptomology.
So we can't go through all these things. We don't have time. But fatigue is a very interesting subject. How could breathing make you feel tired? Well, there's a whole chemistry to it in the kidney. I mean, I could spend an hour just describing kidney physiology to you and how breathing affects it. And you affect that equation and you throw off the kidney's job and you get into trouble. You get things like sodium deficiencies. You can major contributions to chronic fatigue because the kidneys will dump out all the bicarbonates rather than returning the bicarbonates to your body. It dumps them. And then you end up with a bicarbonate deficiency so that if you become, you do exercise and you get lactic acid, the body doesn't have the resources to buffer the acid because of the way you're breathing. You can't buffer the acids because over a period of time you've compromised yourself and lost those bicarbonates, which you need just to walk around. Meanwhile, people are talking about all these symptoms and they're attributing them to who knows what. Their diet, their heavy metals in their body, the stress that they have, who knows what. They have no notion of how they're breathing and how it's affecting them. Now, over-breathing isn't breathing fast. I had someone the other day is breathing at 4 breaths per minute. Beautiful-looking breathing. Diaphragmatic, beautiful breaths. 4 breaths per minute, and he was horrifically hypocapnic. And he's suffering with chronic pain. Extremely low CO2 levels. It's amazing he could even stand up. It's because you can get dizzy and pass out easily by doing this. So cardiovascular, you can get palpitations, tachycardia, arrhythmias. It can trigger angina symptoms, all kinds of ECG changes. This is a big one. Cognitive, changes. Major attention deficit, learning deficits, poor memory, brain fog. So here's a woman pregnant. She's suffering with brain fog and say, oh, that's because I'm pregnant. No, it's because your CO2 level is so low. You depleted the blood to your brain. No wonder you're in a brain fog. I did a demonstration once with one of the directors of the peak performance training program for the special forces, and he had a PhD in mathematics. And I had him over-breathe moderately. He couldn't even count backwards by sevens from 200 with a PhD in mathematics. And he couldn't believe it. He was so astounded that he couldn't function. He was that bad that he couldn't even count.
And also in addition to that, Peter's talking about cardiac responses. There are a lot of people, once they are able to see what their carbon dioxide concentration levels are using the instrumentation, that report they get racing heart, and it happens maybe unpredictably or at certain times, certain situations, and they're medicated for it. But once they learn to regulate their breathing so that the pH is optimal in that range, the cardiac responses may stop in certain situations. The racing heart will return to normal. We had one lady who had been monitoring herself who was on a medication for a racing heart. And when she normalized and was breathing in good chemistry, the racing heart stopped. She thought we did something to the instrument to make it look like
She thought we had
somehow-
rigged it. She was convinced that
Yeah.
we'd rigged it.
Because she could bring on the racing heart, depending on how she breathed, or reduce it. And maybe she didn't need to be medicated for that.
Anyway, so you go here, consciousness, you get dissociation. Now, in a sense, we're dissociated all the time because we're in a particular state. We can't be in all states at once. We're experiencing one aspect of ourselves. And in that sense, everyone dissociates. But what we mean by dissociation here is people kind of disconnect from who they are. They're trying to avoid something. And so they breathe that way without realizing that's how they did it. But dissociation is a really major thing. State change, dizziness, fainting, confusion, and hallucinations. We've seen a lot of people in yoga who have learned different kinds of breathing in yoga who suffer with hallucinations because of the way they're breathing. Okay, that extreme. And of course, it can do things like trigger panic attack in people who find the symptoms disturbing. And that's where they start to panic because they don't know what's going on. Okay, so then you have emotion, anxiety, anger, fear, panic, all that kind of thing gets triggered because when you reduce oxygen to the brain and blood sugar to the brain, you get all kinds of acidosis, neuronal acidosis, lactic acidosis in the neurons, and now everything starts to become dysfunctional. And depending on what you're thinking about or what you're feeling at the moment, it'll exaggerate it. And what it'll do is it'll inhibit, or the inhibitory centers in the brain will no longer inhibit. So now you have a release. Someone will start crying. If you've no doubt seen that if you're a breath worker. People, they breathe a certain way, they start crying, they become emotional and all that. And you get triggering, neuronal triggering in the brain as a result of reducing CO2. They can be very, very dramatic, and the person doesn't understand it. They're out there in their life. They're not in your session. They're out there doing something, and suddenly they feel this, and they, like someone who's doing public speaking, overventilates, and now whatever anxiety they had now goes off the chart because of that effect on the inhibitory centers in the brain. So the anxiety just gets triggered. Mm-hmm. Okay, so there's a real physiological basis for these things. Movement, diminished coordination, reaction time, balance, perceptual judgment, like if you're a race car driver or you're a pilot in an airplane or something like that, it can have a radical effect on you. You have a whole story. I was a pilot for years and years and years. I had a commercial license. I had an airline transport rating. I was really into it. And I had a friend who died, and I know he died because he was hypocapnic, because I was with him when an engine failed, and he was a MOT, Canadian, Ministry of Transport, check ride pilot. He checked all the chief pilots of the airlines in the Northwest Territories and northern part of Canada. And I was with him in a twin-engine airplane, and an engine failed. And an incredible pilot. He had no idea where he was. He was just lost. He misreported his position to the controllers. He didn't know what was going on. And I came in and had to basically coach him to get that airplane back so we could land. I mean, it really has a profound effect, on your ability to make decisions and your hand-eye coordination and so on. Muscles, tetany, you see tetany in people all the time. A lot of what breath workers are doing, you'll see tetany because of this oxygen deficit in the muscles, and you get calcium. Calcium will move from the blood right into the muscles when you breathe that way. And when the calcium gets in there and there's an oxygen deficit, then you start getting these tremors and this tetany. Okay? Then here it plays a major role in sleep apnea, in sports, in looking at rehearsal, being able to focus, endurance, like the LA Police Department, Los Angeles Police Department we've worked with for a long time. They have a whole psychology department there where the cadets that go through the program, some of them flunk out because they can't shoot. And as it turns out, a lot of them can't shoot well because they're overventilating. They can't focus on the target. Peripheral, tingling in the fingers. If you start to get tingling, you know you're overbreathing. You know you're hypocapnic. Numbness, trembling, twitching, shivering, Then you get personality changes. This is a big thing. You get it's like taking a drink of alcohol. Some people, when they take one drink of wine, what happens? They seem like a different human being. Same thing happens with breathing. You can bring out a whole different part of who you are. A different aspect of your personality can emerge easily, just like taking a drug. This is a big subject here. Respiratory shortness of breath, airway resistance, because when you overventilate, it causes bronchial constriction. So if you're worried about an asthma attack and you start to make sure you get more air, what you're doing is you're working against yourself. The bronchioles are going to start to shut down. You're going to feel resistance, airway resistance. You're going to feel like you're not getting enough air. And sure enough, you were right. You were going to have an asthma problem because you changed your damn breathing. And so all those symptoms start coming on because of the way you're trying to prevent that attack from coming. Same thing in the gut with irritable bowel syndrome and so on. Sensory changes like blurred vision. It plays a big role in vision because you get all the vasculature in the eye. You get vasoconstriction in the eye when you overventilate. There's a whole literature on that. How many, how many eye doctors even know anything about that? Okay, and then smooth muscles like the coronaries in the heart will constrict. In the gut, in the eye, in the liver and other organs, and in the placenta. You get radical constriction of the vasculature in the placenta because of the way you're breathing. So the message is there's a lot more to breathing than maybe you knew. That breathing regulates acid-base balance in the body. And optimal respiration, part of optimal respiration is a balanced chemistry in the system. So when you do all this stuff with mechanics, you don't pay any attention to the chemical side, you really, in essence, don't know what's happening. And you'll see that in a demonstration, where people have no idea how they're breathing and how it's affecting them. And then in what we do, they learn how they've learned to breathe. And what you've learned, we'll get into that next, there are triggers for these different habits. But I'm not going to go into that right now. I'm just going to end with this.
Also, during the monitoring, if you get an opportunity to utilize the instrumentation, if you watch others using it as well, oftentimes we can't tell visually looking at somebody if their chemistry is optimal. We really need the instrumentation to tell us, and then also the person interviewing them and telling us as well, so that together our own personal experience with the data gives us a lot of subtle information that we wouldn't otherwise normally have. And you'll see that in the interview as well when you're observing
a lot of people feel really comfortable breathing fast and shallow. You want to change that? You want to say, hey, you're breathing too shallow and you're much too fast. Why would you want to change it? What's wrong with that? The person's comfortable, they feel great, their CO2 levels are high, it's good, respiration is right on the mark. I mean, I'm a person who breathes with very small breaths, and I breathe quite fast. And it's so easy for me. It just feels so good, just this minimal, quiet little breath. That's all I need. I don't need anything more than that, But you want me to go. I mean, fine, you can do that. Just make sure you're not over-breathing, because then you're going to, I just got dizzy just doing that. Okay, here's kind of the conclusion. Statistics suggest that millions of people worldwide suffer with the profound and misunderstood symptoms and deficits brought on by over-breathing, that is, breathing habits, that lead to hypocapnia. Surveys suggest that 60% of ambulance runs in the major U.S. cities are a result of acute symptoms brought on by hypocapnia. That's from Bob Freed. Unfortunately, these kinds of dysfunctional habits are rarely identified by healthcare practitioners. their effects mistakenly attributed to other causes, and their resolutions prescriptive in nature, where focus is on symptoms rather than the causes. And that's what we're going to be introducing you to. We don't do prescriptive anything. We get together with you, and you and I explore what's going on. That's why you fill out those forms. That is the beginning of an interview. Those forms are for an interview, that we will talk with someone, one of you who will volunteer. We will talk together, and we will look at your respiration while we're talking. It's called transactional psychophysiology. And while we're together, you learn about how you're breathing, how it's affecting you, and then you'll probably discover why you're breathing that way. Very often people find out, yeah, they know the origin of it, and then what you can do about it to make a change. So this is from an article of ours that you can get online. It was an article in 2022, Journal of Holistic Healthcare and Integrative Medicine. That journal's out of the UK. It's a medical journal, and this is where this quote comes from. So I think that's it for just introducing you to a little piece of physiology that is really something you should all know if you're doing breathing work. It's really important. This doesn't negate, I want you to understand, none of this is a criticism that we're going to be talking about of anything you're doing. You do what you do, you're an expert in what you do. It's a question of integrating some additional information into what you're doing, so it may help you to understand more of what you're doing, and in working with your client, you may be ultimately more effective. And we have developed this device that you'll see that will allow you to do that. I mean, it really allows you to get to all the kinds of things that we were just talking about. And we have a book that's just come out that actually details exactly how to do this work. So you can just go through the books, like 18 practicums in there, and you can go through and you can learn to integrate it into what you do. It's not a question of changing to what we do. It's a question of what we have. We want it to be available to you to integrate whatever pieces of it you're interested in.
And that way you don't have to be concerned about misunderstanding some of the things, the behaviors you see in clients when they may be overventilating and you're getting the chemistry shifts. You'll know, okay, maybe the carbon dioxide they're ventilating off too much right now, and I'm going to back off in the way I'm coaching, because for that person, they've reached a point where you probably don't want to bring on anything more extreme, especially if there are pre-existing conditions.
So now we're going to take a break before we do a demonstration, but there are a number of things we have to now continue with. But before we continue, and this is the main presentation, do we have any questions or comments before we continue? His hand went up first back there. You, sir?
Just a second.
Obviously,
I don't
your
think it's
acid,
working.
There we go, now we're
There
working.
it goes.
Oh, there it goes.
The acid-base balance equation, there's two parts to that equation, which is your bicarbonate concentration and then obviously your breathing, or your carbon dioxide.
Right.
How do you know that it's actually your breathing and not an imbalance on the bicarbonate concentration? And do you look at those two things together if you have an increased
No.
level?
In
or-
fact, interestingly enough, in medicine, the bicarbonate concentration is usually determined by looking at the CO2 level. They calculate it indirectly. And that's a mistake, because if someone's overventilating because they're in that situation, they feel stressed and they start to overventilate, they're going to get it'll be a faulty conclusion about what the bicarbonate level is. It's rarely is there a bicarbonate issue. You have to be ill. You have to be really compromised, be sick. You know, when you do that form, it asks you about that kind of thing. If you have any issues like that around bicarbonates, there are definitely organic things when you do this work that you need to be aware of, because the reading that you see, you could misinterpret. For example, if you have a cardiovascular issue, then the looking at CO2 level can be misleading, because there's compensation that goes on that I'm not going to go into here. But that's a subject that we take up, like that kind of issue. If you come through one of our major programs or something, we talk about that kind of thing. But it kind of it'll distract us from really focusing on, the average healthy person. But bicarbonates you're not very frequently going to find someone who has compromised bicarbonates, that there's a kidney issue. And very often they know about that kidney issue. You'll see it reported on the form. Okay? Yeah.
I'd like you to maybe clarify what is hyperventilating is.
Hyperventilating?
Yeah, in terms of
Sure.
of
The
volume
word,
of air, because
Yeah.
It seems like the hypercapnoia.
hypocapnia.
Yeah, is directly related to the concentration of CO2 that affects the pH, right?
Yeah.
So that's only about the exhale, right?
Well, that's how you measure it. Well, I haven't talked to you about how we measure CO2 yet. I haven't gotten to that, to tell you how we do it.
Okay, but hyperventilating is an equal amount of inhale and exhale.
Well, let me just
volume?
comment on hyperventilation. Let's see if I can get to your question. Hyperventilation is a clinical term, and it was something that if you could be diagnosed as suffering with hyperventilation. That's gone now. They don't have that. That isn't in the world of assessment. Hyperventilation has disappeared, and hyperventilation has certain connotations, like someone breathing fast, and really it's about losing too much carbon dioxide. It's the same thing, really, as overbreathing, hyperventilation. But it's so connected with negative things, and it has such a bad reputation in medicine and in healthcare, hyperventilation itself. We don't go there, we don't talk about that, because you can be breathing even 2 or 3 breaths per minute and be hyperventilating. You can be breathing very slowly, diaphragmatically, look like you're doing perfect breathing and you're hyperventilating. And that doesn't fit with the notion of hyperventilation that people have. But when you talk about physiology, we talk about hypocapnia, which is a CO2 deficiency. And it's a condition. It's not a disorder. It's a condition. It's a physiological state. So we don't really use the word hyperventilation in any of our work because it's misleading. As soon as you tell someone they're hyperventilating, they immediately do what? Deny it. I don't hyperventilate. Only neurotic people hyperventilate. I don't do that. So when you say hypocapnia, are you overbreathing? People, their eyes open, they get really interested. We went to a Bikram conference once where we had a big sign that says, "Are you overbreathing?" Had a picture of that brain you saw there. It says, "Are you overbreathing?" And we were the busiest booth at this Bikram yoga conference with thousands of people were there in the Los Angeles Convention Center. And we were the busiest place in the entire convention center because everybody wanted to know whether they were overdoing a good thing. Where if you put, "Are you hyperventilating?" we probably would have had no one there. Okay, so we don't talk about hyperventilation. It has a lot of connotations, yeah.
Is there any connection between...
Closer, yeah.
Is there any connection between like dissociative identity disorders or schizophrenia or bipolar, any of these kinds of like really extreme state shifts?
This is a very important thing
Yeah.
you're bringing up because you're talking about, which we look for all the time, are interactions between the way you're breathing and other challenges you have in your life. They may be psychological challenges, they may be physical challenges, it may be both. And what the breathing does is it exacerbates the symptoms and may trigger them trigger the symptoms associated with the disorder, like, say, epilepsy. This is how I got into it. This is my friend Bob Freed, who was doing work in epilepsy in 1984, where as soon as someone who has epilepsy seizure starts to come on, most of them are overventilating. And he was able to teach them to lower the CO2 level whenever they felt they might have a seizure, to keep the CO2 level down, and it reduced the probability of the seizures. And in some cases, people didn't have seizures anymore. It wasn't that there was no epilepsy. It was that it didn't get triggered. So if you keep normal oxygen concentration in the brain, then it's less likely you're going to get a seizure. So the interaction between that organic issue and breathing is a very important thing. And what you find is when people look at a symptom, as soon as they find an organic reason for the symptom, right away, psychology and behavioral science is irrelevant. Because we found the cause, here it is, this physical thing. These things interact all the time. People who have physical disorders are more likely to learn dysfunctional breathing than someone who doesn't have a physical disorder. Like COVID masks. This is a beautiful example of how psychological, breathing is. People put on a COVID mask, and a certain percentage of them feel air hunger, just like that. They feel like they're suffocating. 1 out of 5 people? I did a presentation to a bunch of hygienists, and about 1 out of 5 of them weren't working anymore during COVID times because they couldn't go to the dental, office and with a mask on because they felt like they were going to die. They just wouldn't go. Well, that mask, you put it on, you get air hunger. Obviously, it has nothing to do with oxygen because you put it on, they have air hunger in 2 seconds. I mean, how could you have an oxygen deficit in 2 seconds? They have air hunger. It's a learned response. Air hunger, like fear, is learned. You can learn it to all kinds of situations. Put it on, you have air hunger. Now the person gets all these symptoms I described to you. And how do they interpret those symptoms? I'm over-breathing? No. They say, this is what I thought. I'm suffocating. I'm having, this is terrible. I can't wear the mask. And they take the mask off. Okay? Or what you get in a lot of people, and also you'll get a pseudoscience that builds around. This is a good thing to remember. You get kind of a pseudoscience where what someone does is they find a research study that shows that putting a mask on reduces oxygen concentration from 21% to 19%. I had someone present that to me. Well, it reduces oxygen concentration from 21 to 19%. That's a lot. And that's what's accounting for this, that, and the other thing. That was evidence for his position. In reality, he doesn't obviously know anything about physiology because hemoglobin will carry almost exactly the same amount of oxygen in the body, whether it's 21 or 19%. It doesn't make any difference. Makes no difference at all. But he didn't know that, just less oxygen. Boom, that was proof. That was support for his position. So we find this kind of thing all the time, when people talk about breathing. But anyway,
people who step forward with a diagnosis, like you're mentioning, we often ask, is this a self-diagnosis or is this a medical diagnosis? Because lots of times people like to make claims for their experience with a medical term. It's very helpful for us when we work with people, and when you're working with people as well. We don't speak to diagnoses, we speak to behavior. So if somebody does experience that they feel otherworldly or they're starting to shift in their consciousness, like moving into a dissociative state, or they're starting to feel like maybe they're going to experience a seizure, or starting to feel like asthma is coming on, this is a great learning space, right? But don't want it to come on. If they know what to do to back out of that, you can see on the instrumentation if the chemistry is improving or if it's worsening. And you can start to interact with them to help them reduce and to learn the sensations, to be able to shift out and manage their chemistry and empower them.
And can that also be connected to like a chronic pain flare cycle or a Lyme cycle? Or
Absolutely.
Like any kind of, same
Absolutely.
Kind of thing? Okay.
See, breathing is, I got into it because it's so much more. It's so much more powerful than most people give it credit for. Even if you've been a breath worker for years and years, you don't know about this. I mean, it is unbelievable. That's what really just drew me. It was mind-boggling to me. Yes. Yeah. We have to get on with this. I'll take one more question, but we're not going to get through what we need to do our demo. So.
Hi there. I wonder if you make a distinction between ongoing breathing behavior and breathing exercise for a simple reason that, I mean, us as breath workers, anyone who does Wim Hof or even Breath of Fire, all these exercises actually would be hypocapnic. People they blow off CO2 on purpose. They hyperventilate on purpose.
Right.
And they feel real value in it. We see people change and improve. There seems to be tremendous value in the exercise, and that would seem to fly in the face of what you're saying. Except maybe the distinction is behavior versus exercise. Or is that real?
Well, it doesn't fly in the face of anything. I don't understand why you think it would fly in the face of anything.
Well, because Wim Hof, for example, they're all for hyperventilation.
They're using it as a technique to induce a state. Like I used to take LSD, and I took all those drugs and to create a state so I could learn something and share consciousness with my friends and so on. You do the same thing with breathing. You can just use it to try to learn something, and then you want to be sure that it goes back to normal.
That's right. Well, I think they would say it has physiological benefits, not just the altered state, but there's physiological
A
benefits.
physiological benefit from compromising respiration.
That's what Wim Hof would say.
I'd like to see how in the world he could support. That's my field. That doesn't make any sense. Compromising your respiration is going to be good for what?
I'll give you an example. Tomorrow, if we take an ice bath, and
Ice bath is something else. Yeah.
People who are experienced will do breath work first because it makes the ice bath much easier to handle. So something's going on.
Yeah, I mean, you're just using the breath it's a psychological thing. Whether you do something like an ice bath, you learn something by going through that. And then you're more able to handle something later on. That has nothing to do with what we're talking about here. It's completely irrelevant. You're using the body as a tool to learn something, in this case to adapt to something, so that you can adapt later on and maybe be more successful in doing whatever it is you're up to. We do that all the time with our arms and legs and every part of our bodies. There's nothing unique about that. We're talking about, this doesn't fly in the face of any of that. We're talking about facts. This is physiology. This is how it works. If you go in one direction or another direction, this is what will happen. This is what will happen to calcium. It'll move into the muscles. That'll cause spasm. This will do that. Now, what it means to you experientially, this is this behavioral thing. That's what we get into. That's the psychology of it and what it means to you. So now you can do something better than you did before. You paid a price for it. You compromised your respiration. You had an experience. You jump in cold water at 1 degree Celsius. And you have this experience, and it changes your perspective of something in life because you realize that kind of stress you can handle it, or whatever it is. So, we do that all the time. That's part of what our lives are about. This is basic pulmonary physiology that one needs to learn. It has these effects, like it or not. And whether it's working for you because you learned something from it or not, great, you learned something from it, you did it. Just like when I was in the 60s. I was in the hippie days and actually in the beatnik days. We did all these drugs, not good for you. I did them. And you know what? I learned a lot. I got a lot from it. It was worth it.
I do think you're saying there is a distinction between behavior and exercise. So that a temporary exercise that may compromise your health might actually have benefits, while ongoing behavior does not, like ongoing hyperventilation.
Exercise and behavior are the same thing. Behavior, I have a PhD in this. This is my whole field. Behavior is a physiological action. This is behavior. Talking is behavior. Blinking is behavior. Heartbeat is a behavior. Insulin production is behavior. Digestion is behavior. Going like this is behavior. Breathing is behavior. All of these things are behaviors.
Maybe you're talking about recovery, the ability to recover after going into the water. So if a person continues to overventilate, moving out too much carbon dioxide and creating vasoconstriction in the brain, if they continue to do that, maybe they'll pass out. You don't want them passing out in the water.
Of course not. There's a rule. There's some very clear rules about that.
Yeah.
But I do this all the time in very cold situations. breath work will stop you from getting as cold if you do it. I've done it as many times. So,
Well, sure,
and that's
because-
why the practice exists, I think.
See, that's what you're saying is fabulous. But it doesn't have anything to do with contradicting or being opposite to anything we're talking about.
I'm not saying I'm not contradicting. Just saying is maybe that an individual exercise technique might be different from ongoing behavior.
Well, there's also the fact that Wim Hof says he does this every single day for the past like 45 years, right? He says he hasn't been sick for 40 years or 45 years.
So I haven't either, and I haven't done Wim Hof. They're all, see, our work isn't about breathing. We don't have breathing techniques. You say, Litchfield, Raymer, what are your techniques? We have none. We don't, that's not our work, which I'm going to get into now. Our work has nothing to do with any kind of breathing techniques. Our work is about breathing, not using it. Like, you know, like my arm, I'm using it right now. And I can have all kinds of techniques, different ways I can move my arm, you know, and all these different things. And you can move your arm to do this, you can move your arm to do that, and you can do endless things. But then there's the physiology of the arm, which is relevant to all of those things, you know. So we're talking about, we're interested in breathing, not using breathing as a technique. We simply don't do that. And that's great that people do it, just like you can use your arm in lots of different ways. Breathing you can use for all kinds of things. But that's not what we do.
And also, if you want to speak with Lisa about that as well, when we set up instrumentation, she's available to speak specifically to that if you want.
Okay, so we need to move on. I was just saying, we don't do breathing techniques. What we do is we look at how are you breathing, how is it affecting you, and what can you do to change it, if you need to, if it's important to change it. And, you know, it's not about how you're breathing in general. It's about how you're breathing very specifically in specific situations, because you can hook someone up and their respiration is perfect. They're really beautiful. You know, when I see that, what does it mean to me? Nothing. Why? Because breathing habits every habit has a trigger. There's no trigger, that's all. You're breathing well now, that means at least some of the time you can breathe well. But what we do is we find out in those circumstances when the habit is triggered, like you're standing in front of an audience, and then that's when you start to overventilate. That is when things go wrong. And so we identify the triggers that are involved. So it's not a question of just hooking someone up and say, oh, you're fine. I mean, it's like in medicine. Oh, you've got good blood pressure, you're fine. That isn't, you're not looking at it as a behavior. And that's what you're going to be learning about. We'll just take a break, and I'm going to say a little bit about it, how we do it, and then we're going to demonstrate how we do this kind of work, as you'll see. So anyway, just take a break.